Good afternoon, and thank you for joining us for the expanded Home Health Value-Based Purchasing, or HHVBP Model, Calendar Year 2024 Annual Performance Report webinar. My name is Jackie Stempinski from Econometrica, and I will be your host for today's presentation. If you would like to download the presentation, please follow the link provided in the chat. Before we proceed, I'd like to take a moment to review the disclaimer for this training. This presentation was current at the time it was published or uploaded onto the web. Medicare policy is subject to change, so links to the expanded Home Health Value-Based Purchasing, or HHVBP web pages have been provided as supplemental resources for your reference. This presentation was prepared as a service to the public and is not intended to grant rights or impose obligations. This presentation may contain references or links to statutes, regulations, or other policy materials. The intent of the information provided is to be a general summary and not to take place of either the written law or regulations. We encourage readers to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. Today's agenda will include the following topics: welcome and introductions, what is the expanded HHVBP model, calendar year 2024 APR, eligibility, cohorts and model years, expanded HHVBP model applicable measure set, interpreting your agency's calendar year 2024 APR, the appeals process, public reporting, resources, followed by a Q&A session. Now I would like to introduce today's presenters. Our first presenter is Brenda Carcos, an RN and a senior associate at App Global. Brenda is a subject matter expert with expertise primarily in hospice, oncology, and home health. She has worked in a variety of clinical settings and roles throughout her nursing career, including direct patient care, senior management, quality, and staff education. She has developed and presented numerous trainings related to the post-acute care and the hospice quality reporting programs for CMS. Our second presenter is Marissa Rochin, PhD and an associate at Apt Global. Marissa is an expert in quantitative data analysis of large patient-level datasets, quality measure development, and monitoring of organizational performance trends. Her project work includes the Home Health Quality Reporting Program, or HHQRP, and the expanded Home Health Value-Based Purchasing Model. Additionally, Marcy O'Reilly from the Centers for Medicare and Medicaid Services and Program Coordinator for the HHVBP Model will be joining us for this presentation. The objectives for today's training include describe the expanded HHVBP model, define key concepts of the calendar year 2024 APR, summarize performance periods and minimum data thresholds by quality measure category, interpret total performance score, or TPS, and annual payment percentage, APP, using the information provided in the calendar year 2024 APR. And explain how to initiate the appeals process for the calendar year 2024 APR when applicable. During the event, a navigation panel can be accessed from the bottom of the screen. This will allow you to send messages and reach out for assistance in the chat and ask questions through the Q&A. You have the option to hide chat notifications throughout the presentation by clicking on the small arrow to the right of the chat button. As resources are reviewed throughout the presentation, links will be provided in the chat to allow you to access those resources quickly and easily. Additional resource links and a list of acronyms can be found at the end of the presentation. And as a reminder, today's event is being recorded. Let's practice the polling function with these next two questions. These questions will be collected anonymously to get a better idea of attendee knowledge and experience. You should now see the polling question and responses in a separate window on your screen. We will provide a few moments as responses are collected for each polling question throughout the presentation. So for the first question, how often do you access the expanded HHVBP model webpage? Once a week or more often? Once a month? A few times per year? Or I have not accessed or I am not familiar with the expanded HHVBP model webpage. Please take a moment to respond to this poll in the separate polling window. Okay, now we'll move on to the next question. How long have you been in your current role within your home health agency? More than 10 years, 5 to 9 years, 1 to 4 years, or I am new to my current role. Okay, thank you everyone for entering in your polling questions. I am now going to hand off to Brenda Carcos to begin the presentation.
Thanks, Jackie. So let's start by summarizing what the expanded HHVBP model is. In 2016, the Center for Medicare Medicaid Innovation implemented the original HHVBP model in 9 states. The states were Arizona, Florida, Iowa, Maryland, Massachusetts, Nebraska, North Carolina, Tennessee, and Washington. The expanded HHVBP model began in 2022 and includes Medicare certified HHAs in all 50 states, the District of Columbia, and the U.S. territories. The expanded model is designed to support greater care quality and efficiency among home health agencies nationally. Medicare payments made to participating HHAs are dependent on their performance on 12 quality measures relative to their peers, which also is referred to as value-based payments. An HHA's performance on this set of 12 quality measures, which is discussed on a later slide, are made available to HHAs via the Internet Quality Improvement and Evaluation System, or short for IQES, in the form of 2 types of reports. 4 quarterly interim performance reports, or IPRs, published in January, April, July, and October, respectively, and 1 annual performance report, or APR, published in August of each calendar year. Let's look at the performance metrics. The 2 key performance metrics used in the HHVBP model are the total performance score, or TPS, and the annual payment percentage, or APP. The TPS is a numeric score ranging between 0 and 100. The annual payment percentage, APP, is derived from the TPS that ranges between -5% and +5%. This percentage is applied to the payment for each submitted final Medicare fee-for-service claim with a payment episode through date in calendar year 2025. In addition to the 2 key performance metrics we reviewed on the previous slide, we'd like to discuss 3 additional concepts that are important for understanding the calendar year 2024 Annual Performance Report, or APR. And that is eligibility, the cohorts, and the model years. Let's start with eligibility. Model participation is mandatory for all Medicare certified HHAs with a CMS certification number, or CCN, in the 50 states, District of Columbia, and the U.S. territories that receive payment from CMS for home health services. Each HHA competes with other HHAs within one of 2 nationwide volume-based cohorts on a set of quality measures. To be eligible to receive a calendar year 2024 APR, HHAs must be Medicare certified prior to January 1, 2022, and they must have sufficient data for at least 5 out of the 12 quality measures to calculate a TPS and the APP. Now let's take a look at the cohorts. Cohorts are based on an HHA's number of unique survey-eligible beneficiaries for the Home Health Consumer Assessment of Healthcare Providers and Systems, or HHCAPS survey. The cohorts for calendar year 2024 APR were determined based on the number of unique HHCAPS survey-eligible beneficiaries in calendar year 2022 and are defined as smaller volume and larger volume cohorts, respectively. The smaller volume cohort includes HHAs with fewer than 60 unique HHCAPS survey-eligible beneficiaries in the calendar year prior to the performance year. The larger volume cohort includes HHAs with at least 60 unique HHCAPS survey-eligible beneficiaries in the calendar year prior to the performance year. This slide provides an overview of the calendar years that are relevant to the calendar year 2024 APR, namely the baseline year, performance year, publication year, and payment year. The baseline year is calendar year 2022 and is used to calculate quality measure specific achievement thresholds, benchmarks, and improvement thresholds. Calendar year 2023 is the performance year, and HHA performance in this calendar year is measured against 12 quality measures relative to performance of HHAs in each cohort. The publication year of the calendar year 2024 APR is calendar year 2024. And finally, calendar year 2025, which is the payment year. That means that payment adjustment ranging from -5% to +5% are applied to Medicare fee-for-service claims with through dates in calendar year 2025. Now I'll turn it back to Jackie for a knowledge check.
Now that we've gone over several key performance metrics and concepts used in the HHVBP model and relevant to the calendar year 2024 APR, let's test our knowledge. Which model year is the performance year for the calendar year 2024 APRs? Is it A, calendar year 2022, calendar year 2023, calendar year 2024, or D, calendar year 2025? We'll give you a few moments to select your response. If you selected B, calendar year 2023, you are correct. Calendar year 2023 performance is measured against 12 quality measures relative to the performance of the HHAs in each cohort. Now for one more knowledge check. How is the smaller volume cohort defined for the calendar year 2024 APRs? Your choices are: includes home health agencies with fewer than 60 quality episodes of care in calendar year 2022, includes home health agencies with fewer than 60 quality episodes of care in calendar year 2023, includes home health agencies with fewer than 60 unique HHCAPS survey-eligible beneficiaries in calendar year 2023, or includes home health agencies with fewer than 60 unique HHCAPS survey-eligible beneficiaries in calendar year 2022. Once again, we'll give you a few more moments to make your selection. And D is the correct answer. The smaller volume cohorts include HHAs with fewer than 60 unique HHCAPS survey-eligible beneficiaries in calendar year 2022.
Okay, so now let's move on to reviewing the 12 quality measures used in the HHVBP model. Note that we won't go into detail about each quality measure. The HHVBP model webpage has several helpful resources that will provide a comprehensive description of each quality measure. There are 5 OASIS-based measures in the HHVBP model. These are discharge to community, improvement in dyspnea, improvement in management of oral medications, total normalized composite or TNC change in mobility, and TNC change in self-care. The 2 claims-based measures used in the HHVBP model are acute care hospitalizations during the first 60 days of home health and emergency department use without hospitalization during the first 60 days of home health. The 5 HHCAPS survey-based measures are care of patients, communications between providers and patients, specific care issues, overall rating of home health care, and willingness to recommend the agency. Note that only HHAs in the larger volume cohort are eligible to have their HHCAPS survey-based performance included in their TPS. Now I'll turn the presentation over to Marissa to continue.
Thank you, Brenda. In this next section, we are going to walk through a calendar year 2024 APR for a sample agency to help you interpret your agency's report. If you are unsure about how to access your agency's 2024 APR, please refer to the resources listed on this slide for detailed instructions on this process. This diagram shows the conceptual model of how agency performance on up to 12 quality measures turns into the annual payment percentage, or APP. At a high level, on each quality measure with sufficient data, an agency can earn achievement points and improvement points. The higher of the achievement points or improvement points turn into care points. Those care points are then weighted and summed to one score, the total performance score. The final step is to generate the annual payment percentage derived from your agency's TPS. Keeping this conceptual model in mind, let's review what achievement points are. An agency can earn between 0 and 10 achievement points for each quality measure. An agency's performance year measure value must exceed the quality measure's achievement threshold to receive achievement points for that quality measure. The formula for calculating achievement points is displayed on this slide and is also shown in the footnotes on the Achievement tab. On the next slide, we will review the 3 components that go into the achievement points formula. The first component is the agency performance score, which is the risk-adjusted value for each quality measure based on the agency's performance in calendar year 2023, when sufficient data are available. Sufficient data is defined differently based on the measure category. That is, 20+ quality episodes or stays for OASIS-based or claims-based measures, and 40+ surveys for HHCAPS survey-based measures. The second component is the achievement threshold, which is the median of agency's performance on each quality measure in calendar year 2022, calculated separately for each volume-based cohort. And finally, the benchmark, which is the mean of the top decile of agency performance on each quality measure in calendar year 2022, again calculated separately for each volume-based cohort. Here you see a screenshot of the Achievement Points tab. This tab contains the following information: the list of applicable measures by category, and then for each applicable measure, performance year data period, your agency's value, your cohort's achievement threshold, and your cohort's benchmark, and finally, your agency's achievement points and maximum possible achievement points. Now let's work through an example of how to calculate achievement points for the OASIS-based measure, improvement in dyspnea.
All three components that go into the achievement points formula are reported on the achievement points tab and just need to be plugged into the equation. Taking improvement in dyspnea as an example, the HHA performance score is 88.431. The achievement threshold is 82.042, and the benchmark is 96.651. Using these inputs, the formula generates 4.373 achievement points. A few notes to keep in mind. An agency with a performance score greater than or equal to the benchmark receives the maximum of 10 points for achievement. An agency with a performance score greater than the achievement threshold but below the benchmark receives greater than 0 but less than 10 points for achievement by applying the achievement score formula. An agency with a performance score that is less than or equal to the achievement threshold receives 0 points for achievement. Let's move on to improvement points. An agency can earn between 0 and 9 improvement points for each quality measure. An agency's performance year measure value must exceed the quality measure's improvement threshold to receive improvement points for that quality measure. The formula for calculating improvement points is displayed on this slide and is also shown in the footnotes on the Improvement tab. On the next slide, we'll review the three components that go into the improvement points formula. The first component is the agency performance score, which is the same value used to calculate the achievement points. The second component is the improvement threshold, which is the agency's baseline year performance score for each quality measure with sufficient data in calendar year 2022. And finally, the benchmark, which is the same value used to calculate the achievement points. Here you see a screenshot of the Improvement tab. This tab contains the following information: the list of applicable measures by category, then for each applicable measure, the performance year data period, the baseline year data period, your agency's performance year measure value, your agency's improvement threshold, and your cohort's benchmark. And finally, your agency's improvement points and maximum possible improvement points. Now let's work through an example of how to calculate improvement points for the OASIS-based measure improvement in dyspnea. All three components that go into the improvement points formula are reported on the Improvement tab and just need to be plugged into the equation. Taking improvement in dyspnea as an example again, the agency performance score is 88.431. The improvement threshold is 82.038, and the benchmark is 96.651. Using these inputs, the formula generates 3.937 improvement points. Again, a few notes to keep in mind. If the agency performance score is less than or equal to its improvement threshold for the measure, the agency receives 0 points for improvement. If the agency performance score is greater than its improvement threshold, but below the benchmark, the agency receives an improvement score that is greater than 0 and less than 9, based on the improvement score formula. Now let's look at care points. Care points are the higher of achievement or improvement points for each quality measure. For example, if your agency has 6 improvement points and 1 achievement point for a given measure, care points are derived from the improvement points, which results in 6 care points. If your agency has 9 improvement points and 10 achievement points for a given measure, care points are derived from the achievement points, which results in 10 care points. Let's apply this rule to our improvement in dyspnea example from the previous slides. In the example shown on this slide, the sample agency earned 4.373 achievement points and 3.937 improvement points. Since the achievement points are higher than the improvement points, the care points for this measure are 4.373. Now that we have defined what care points are, we are ready to move on to the total performance score, or TPS. The sum of each quality measure's weighted care points is defined as the TPS. OASIS-based and claims-based measures are weighted at 35% each. HHCAP survey-based measures are weighted at 30%, accounting for 100% of the TPS. If an agency does not have all measure categories available, the measure weights are redistributed accordingly. For example, if an agency doesn't have sufficient data for HHCAP's survey-based measures, the measure weights for ACES-based and claims-based measures are 50% respectively. As shown in the table on the right, within measure categories, individual measures are weighted differently. Specifically, the two TNC measures are weighted 1.5 times the other ACES-based measures, and the claims-based ACH measure is weighted 3 times the EDU's measure. All HHCAP's survey-based measures are weighted equally. Note that an agency must have sufficient data to calculate care points for at least 5 quality measures to receive a TPS and an annual payment percentage. If the TPS is the sum of the applicable measures' weighted care points, how are the weights we just reviewed applied to the care points? The Measure Scorecard tab pulls all this information together. Going back to our improvement in dyspnea example, we can see that the weighted care points, also called weighted measure points, are 2.551, which is derived by dividing the care points of 4.373 by the maximum possible points of 10 and multiplying the results by the measure weight of 5.833. For the sample agency, adding up all weighted care points results in a TPS of 23.411, which is associated with the second lowest percentile ranking compared to the agency's cohort's performance. The TNC Change Reference tab contains information to assist agencies in understanding their unadjusted or observed performance on the individual ACES items included in the 2 TNC measures, namely the percentage of episodes in which there was no change, positive change, or negative change between admission and discharge for each OASIS item at the agency level and the cohort level. The annual payment adjustment is the percentage by which an agency's final claim payment amount under the HHPPS changes in accordance with the payment adjustment methodology described in section 484.370. The APP range is -5% to +5% and is applied to final Medicare fee-for-service payments in calendar year 2025. In general, if the APP is positive, the payment amount increases according to the APP. If it's negative, the payment amount decreases according to the APP. The amount of each agency's payment adjustment is dependent on the agency's TPS and the performance of other agencies in the agency's volume-based cohort. In 7 steps that are outlined in the table on the right, the TPS turns into the agency's annual payment percentage, or APP. The annual payment adjustment tab that we are going to review on the next slide includes these steps and corresponding descriptions, as well as the resulting intermediate values in detail so you can calculate along. Now, this is a screenshot of a part of the annual payment adjustment tab. Each step to get from your agency's TPS to your agency's APP is shown in the first table. Not shown on the slide are the footnotes that go along with the first table, describing each step in detail. The second table provides additional cohort-level statistics to gauge your agency's performance to other agencies in your volume-based cohort. The AT and BM tab shows the final achievement thresholds and benchmarks for both volume-based cohorts for each of the 12 quality measures used in the HHVBP model. All achievement thresholds and benchmarks are based on calendar year 2022 performance for the smaller volume and larger volume cohort, respectively.
Let's pause to check our knowledge. What is the maximum payment adjustment percentage agencies can achieve? Is it between -3% and +3%? Between -4% and +4%? Between -5% and +5%? Or between -6% and +6%? And the correct answer is C, between -5% and +5%. Now I will turn the presentation back to Brenda.
Thank you, Jackie. So HHAs have the opportunity to appeal their performance published in the calendar year 2024 APRs. Let's review the appeals process in the next few slides. The calendar year 2024 APR is published in 3 versions: a preview APR, a preliminary APR, and a final APR. The preview APR is followed by a recalculation request period. The preliminary APR is followed by a reconsideration and administrative review period. Let's go over each of these in detail. So after the preview APRs are published in August, HHAs have 15 calendar days to submit a recalculation request if they find evidence of an error in their report. CMS then investigates the submitted requests, makes adjustments or corrections if needed, and notifies HHAs of the decision. Once preliminary APRs are published in September or October, HHAs have 15 calendar days to submit a reconsideration request if they submitted a recalculation request and are not in agreement with the recalculation request decision. CMS then investigates requests, makes adjustments or corrections if needed, and notifies the HHAs of the decision. HHAs also have 7 calendar days to submit a request for administrative review if they submitted a reconsideration request and are not in agreement with the reconsideration request decision. Again, CMS investigates the requests, makes adjustments or corrections as needed, and notifies the agency of the decision. CMS makes the final APR available after all reconsideration requests are processed and no later than 30 calendar days before the payment adjustment takes effect on January 1, 2025. Now I'll turn back to Marissa.
Thanks, Brenda. Let's briefly discuss what's on the horizon in terms of HHVBP public reporting. HHVBP public reporting will begin in early 2025 through the Provider Data Catalog, or PDC. CMS will publish each quality measures benchmark and achievement threshold by volume-based cohort. For each agency that qualified for a payment adjustment based on calendar year 2023 performance, the applicable measure results and improvement thresholds, the TPS and TPS percentile ranking, and the adjusted payment percentage. I will now turn it back to Brenda.
Thank you, Marissa. So now we'll review some of the many resources that are available to providers about the expanded HHVBP model. For questions, or if you're interested in receiving additional information and updates, you can subscribe to the HHVBP Model Expansion Listserv. You can also contact the HHVBP Model Help Desk at hhvbpquestions@cms.hhs.gov. Some of the additional resources you can access are listed here, and those include the expanded HHVBP Model webpage, the expanded HHVBP Model YouTube playlist, the calendar year 2024 HHPPS final rule, the expanded HHVBP Model guide, the expanded HHVBP Model FAQs, and the instructions for accessing HHVBP Model reports in iKeys. For a list of home health resources and help desks, you can print out this page, which includes all of the different resources as well as their websites. Thank you.
Thank you, Brenda and Marissa, for reviewing these topics with us. And thank you to everyone who's been attending. We will now move on to our Q&A session, where we will answer some of the questions that we have received during this presentation. We will attempt to answer as many questions as we can, and those which are not answered live today will be included in a post-event Q&A document or forwarded to the appropriate help desk. Give me one moment and I will get those questions started. Okay, so for our first question, it says, our home health agency did not receive an annual performance report. Why is this? I'm gonna hand that to Marissa, if you can answer that question.
Sure, thanks, Jackie. So the calendar year 2024 APRs are not published yet. The preview versions of these reports will be published on Friday, August 23rd. And just a quick note here regarding eligibility. To be eligible to receive a calendar year 2024 APR and the corresponding payment percentage, the agency must have a Medicare certification date before January 1st, 2022, and have sufficient data for at least 5 quality measures in calendar year 2023 to calculate a total performance score and annual payment percentage.
Okay, thank you, Marissa. Okay, for our next question, the most recent HHVBP report available for our agency is the preliminary July 2024 IPR. What is the difference between the July 2024 IPR and the calendar year 2024 APR? And if you could answer that one as well, Marissa.
Yes, that is a really good question. So the IPRs are based on the 12 most recent months of performance data. Annual performance reports, on the other hand, are based on data during a given performance year, which is a full calendar year. And again, the calendar year 2024 APRs are based on performance in calendar year 2023 for all measure categories. Really, the most important difference is that IPRs are not connected to payment, whereas APRs are. So your agency's performance reported in the calendar year 2024 APR is connected to payment in the payment year, which is calendar year 2025.
Okay, thanks again. Next question. How can our agency compare its performance to other home health agencies in the same cohort? Brenda, are you able to answer that one for us?
Sure. Hi there. So each home health agency will be able to compare their performance to other agencies in the cohort using the IPRs that are issued quarterly and the APR. So both the IPR and APR include TPS statistics for the HHAs assigned cohort, which provides the TPS for the 25th, 50th, 75th, and 99th percentiles for your HHA's cohort. So this information provides each agency with the opportunity to see how their TPS compares with others within their cohort. And the APR does include the final TPS adjusted payment percentage, or APP, for the mean, the 25th, the 50th, 75th, and 99th percentiles for the HHA's cohort.
Great, thank
Back to you.
Thanks. All right, next question. What's the mechanism to appeal the results in the calendar year 2024 APR? Marissa?
Thanks, Jackie. Just as a reference here, we describe this process in the appeals process section of this webinar. That's slides 48 through 51. In essence, agencies have three opportunities to appeal: a recalculation request period, then a reconsideration request period for those agencies that disagree with the decision made in response to the submitted recalculation request, and finally, an administrative review request period for those agencies disagreeing with the decision made pertaining to the submitted reconsideration request.
Great, thanks. Okay, for our next question, is HHVBP performance going to be reported on Care Compare? I'll hand that one to you, Marissa.
Yes, absolutely. So CMS did consult with a technical expert panel, or TEP, earlier this summer to get feedback on reporting HHVBP performance on Care Compare. And the general consensus among TEP members was that public reporting on Care Compare would need additional time to consider which information is most beneficial for those using Care Compare to help make informed care decisions, and really how to present this information in a straightforward and clear way. Until then, public reporting will remain on the Provider Data Catalog, or short PDC.
Okay, thanks. Next, what is the billing process for the expanded HHVBP model? Brenda?
Sure, I can take that one. So once CMS calculates the HP for those home health agencies eligible for a payment adjustment, the following process will be followed for Home Health Prospective Payment System, or the HHPPS claims for Medicare fee-for-service beneficiaries. So first, the HHA submits a final claim as usual. Secondly, the Medicare claims processing system will review the claim, calculates the payment, and then applies the APP to that claim. And then the Medicare Administrative Contractor, or the MAC, pays the claim and returns the remittance advice with the claim. It's important to note that the adjustment amount is not separately identified on the remittance advice. For any additional questions you might have about billing, you can visit the Home Health PPS webpage. Thanks, Jackie.
Great, thanks. Okay, next, how are the payment adjustments applied? Brenda, if you can do that one as well.
Sure. So payment adjustments are the amount by which the HHA's final claim payment amount under the HHPPS is changed based on the payment adjustment methodology. So if it's positive, the payment amount increases according to the APP, and if it's negative, the payment amount will decrease according to the APP. Now, CMS applies the APP to Medicare fee-for-service payments. HHH episodes can span the calendar, so claims with through dates in 2025 will get the 2025 payment adjustment, even if the episodes began prior to 2025. So Medicare HHPPS adjustments are not made to the aggregate revenue, but occur for each final Medicare fee-for-service claim an agency submits with a payment episode through date in the expanded model payment year, which in this case is calendar year 2025.
Great, thank you. We'll move on to another question. Is there any risk adjustment for the quality measures that are included in the calculations impacting the annual payment percentage? Marissa?
The short answer is yes. So one of the key components for calculating both achievement points and improvement points is the HHA performance score. And this score is a risk-adjusted value for each quality measure based on the agency's performance when sufficient data were available. And sufficient data is defined as at least 20 quality episodes or stays for OASIS-based or claims-based measures, and at least 40 surveys for HHCAPS survey-based measures. The risk adjustment models are calculated at the agency or CCN level and are developed specifically for each measure to compensate for differences in the agency's patient populations.
Thank you. Okay. Are HHCAPS survey-based measures included in TPS calculations for the smaller volume cohort? Brenda?
Sure, I can answer that. So no, the HHCAP survey-based measures are not reported or included in the TPS calculations for the smaller volume cohort. The expanded model national cohorts were constructed to group home health agencies of similar size that are likely to receive scores on the same set of measures for the purposes of setting benchmarks and achievement thresholds and determining payment adjustments. So these HHCAP survey-based measures are not calculated in expanded model performance reports for the smaller volume cohort, and therefore no achievement thresholds or benchmarks are calculated.
Great, thank you.
Thanks, Jackie.
Okay. What if a home health agency does not meet the minimum of 5 applicable measures to receive a TPS and a corresponding payment adjustment? Marissa?
Sure. Thanks, Jackie. Yeah, that's a good question. So an agency that doesn't meet the minimum threshold of episodes or completed HHCAP surveys on 5 or more applicable measures for a given performance year, which is, again, calendar year 2023 for the calendar year 2024 APRs and 2022 baseline year, will not receive a TPS or be subject to a payment adjustment for their respective payment year, which is calendar year 2025. Instead, the agency will be paid for services in an amount equivalent to what would have been paid in accordance with a home health prospective payment system. But agencies will have the opportunity to receive a TPS in the next performance year and be eligible for a payment adjustment in the corresponding next payment year.
Okay, thanks. I think we'll have just one more question to go over. When will an agency receive 0 achievement points and 0 improvement points for some of the quality measures on the calendar year 2024 APR? Marissa, if you can answer that one.
Sure, I'm happy to take that question. So an agency will receive 0 achievement or improvement points if the performance year measure value is worse than or equal to the cohort's achievement or improvement threshold, respectively. And just for later reference, you can review slides 29 and 33, which go over the definitions of achievement and improvement points, respectively.
Okay, thank you, Marissa and Brenda, for answering those questions and providing your presentation. Again, we're going to provide a Q&A document for any of the questions that you've submitted that were not answered. And if it's a question that we cannot include, we can forward it to the appropriate help desk. Okay, so we're gonna
Hey, Jackie, it's
Yeah.
Marcy. Can I
Hi,
just say
Marcy.
a couple words?
Sure.
I want
Thanks
to thank
for-
everyone for participating today and we had some very thoughtful questions that came in. I've been monitoring the questions, and I just want to remind, if you have a question that is really related specifically to your agency, please submit that to the HHVB questions at cms.hhs.gov, but make sure you include your CCN so that we can investigate it for you. But there were some really, really good questions, and we couldn't get to them all, and some of them, we don't want to answer on the fly. So I just want to say, we're not ignoring you, that your question, because they're all important questions. So, just thanks for everyone who, listened in today, and we'll get back to you with either the QA document, and then if you find that your question wasn't answered in the QA document, please, I've been copying and pasting just so that I have them for my own notes, so that we can get an answer to you. If you don't see it there, just send it to the HHVBP help desk. So we want to answer your questions. So I hope everybody has a great rest of their day. And I don't know if Jackie, you have something else to say about it.
Sure. Thanks so much, Marcy, for clarifying all of that. Yeah, we try to get to as many as we can, as she said. So for now, this concludes the webinar. And I'd like to thank our presenters and Marcy for sharing their knowledge on today's webinar. This presentation is recorded, and we will provide a recording of this webinar on the HHVBP Model webpage. You can follow the link in the chat to sign up for notifications when resources are released or future trainings are available. Thank you so much for attending, and enjoy the rest of your day.